नहमदुहु व नसल्ली अला रसूलिहिल करीम अम्मा बाद फ़अऊज़ु बिल्लाहि मिनश शैतानिर रजीम बिस्मिल्लाहिर रहमानिर रहीम Assalamu alaikum and good afternoon everybody. I was given this topic of backache to be explained in 20 minutes. I don't think it's a topic of 20 minutes, but I'll try to summarize, and I would definitely skip the portion that Dr. Umar Abasha has already talked about, the seronegative spondyloarthropathies. So I'll be dealing with just with causes of backache, ways to make a diagnosis, and how to approach the patient, and what are the general principles about the treatment of backache. First of all, what is chronic low back pain and its prevalence? If I may ask all of you in the audience, how many of you ever had a back pain in your life? Can you raise your hands? Almost everybody had one, right? And how many of you got an MRI done or got a surgical treatment for that? Just one person. So it means backache is quite prevalent in the community. Almost everybody gets a backache. So if you look at the epidemiology, by the age of 20 years, 50% of the patients have experienced backache, and by the age of 60, it goes up to 60 to 80%. There was a point. Thank you. So by the age of 60-80% of the people experience backache. So this is a very prevalent condition, very commonly seen in the society. 20% of the U.S. population develops back pain every year. It is the second most common cause of disability in U.S. and leading cause among men, accounting for about 16.5% of the total disabilities in people more than 18 years of age. So if you look at the natural history, there was a study conducted by people in Amsterdam, Netherlands. What they did was they posted postal questionnaires over a period of 12 months to 443 low back pain patients. General practitioners participated in this study. 269 patients completed the survey. It was found that the 7-week time was median time to recover from an episode of backache. At 12 weeks, 35% of the patients were still complaining of backache, and by 52 weeks, 10% still had low back pain. So pain and disability was less during relapse of an attack as compared to the first attack, and time to relapse was median of 7 weeks, and duration of relapse was about 6 weeks. We conducted a little study. It was a retrospective chart review in rheumatology clinic in a tertiary referral center in Karachi. We reviewed the chart of 5,669 patients who visited our clinic between January 2003 and December 2005. And we picked up the diagnoses written on the charts, and we found that 1,549 patients, that was 27.3% of the patients visiting the rheumatology clinic, came with back pain as primary reason of their visit. Out of those, 245 patients had inflammatory backache, that comes to around 16%. There seems to be a higher percentage if you compare it with internationally published data. And one of the possible explanations, we never got the statistical analysis and everything else done about it. But possible reason is that we are a specialized referral center, and people coming to our clinics are basically, they have had initial primary workup for their back pain, and they are referred by general physicians and general practitioners around the city and from around the country when they are suspected to have some unusual cause of back pain. That could be the reason why we had a higher percentage of inflammatory back pain. 372 patients had radiculopathy. 159 patients, that's about 10.26%, had osteoporosis either with or without fracture. 17% had some sort of a malignancy or tumor. 10 had infection, which is a little lower because the infection patients are usually primarily the POTS disease or tuberculosis 9. They are picked up in the community and treated over there, so they hardly ever get referred to a rheumatology clinic for that purpose. Out of those patients, 693 patients had mechanical reason of back pain, which could be myofascial, fibromyalgia. That comes to 44.73%, although if you look at the statistics internationally, 85% of the chronic back pain is basically mechanical. So in our population, when we studied, there was a lower percentage of mechanical back pain because, as I mentioned earlier, mechanical back pains are picked up and treated earlier before getting referred to a rheumatology clinic. and 3.42% of the patients had other unspecified diagnoses. Now, if you look at the back pain definition, patients generally describe back pain as pain starting somewhere below the neck down to the buttock area. But for characterization purposes, the pain that occurs in an area with boundary between lowest rib and the crease of buttocks is described as back pain, and it is quite frequently referred to the thigh areas. When do you call it a chronic back pain? Because anybody can have acute back pain, but there has to be criteria defined for calling it chronic back pain. That is, if the duration is greater than 3 months and the pain persists for longer than expected period of time for certain specific reason, the time it should take for healing. Common causes of back pain, there is a long list. 10 common causes are muscle strain, myofascial pain, disc herniation, facet syndrome, spinal stenosis, spondylosis or spondylolisthesis. These are all mechanical causes, and spondyloarthropathies, which include seronegative spondyloarthropathies, including the reactive arthritis, Reiter's, ankylosing, and psoriatic arthritis, fracture, infection, or tumors. There are certain common risk factors in everyday life which make a person more prone to develop backache, and we should try advise the patient, counsel them, educate them to avoid these things. These are heavy lifting, prolonged driving, especially the commercial truck drivers and people like that, especially on the streets of Karachi, which are very nice, as you all know, tend to develop backache very frequently. Then jogging for a prolonged period of time, weak trunk musculature, obesity, pregnancy, and other psychosocial factors, as well as cigarette smoking, because that can make a person more prone to develop osteoporosis. 85% of patients have mechanical backache, as I said, and the causes could be muscular, ligamentous, tendon strain, discogenic disorders including the prolapsed intervertebral disc, epiphyseal joint arthritis, spinal stenosis, spondylosis, or scoliosis as a cause. The pain could be arising from superficial structures. It could be superficial somatic from the skin, or deep somatic coming from structures deep down like muscle, joint, tendon, bursae, etc. It could be originating from the nerve root irritation, when we call it a radicular pain. It could be a visceral referred pain, neurogenic or psychogenic. Patients describe pain intensity in various ways. So it's usually minimal when it doesn't interfere with the patient's daily activity and patients continue to do normal functioning. It's mild if there is only mild limitation of daily activities or mild limitation of function. Moderate when it alters the function significantly in patient's life, and severe when it is incapacitating or disabling. Diagnostic evaluation. Unfortunately, physical examination, including a neurological examination, can identify only less than 20% of the patients with back pain and come up with a specific diagnosis. So even thorough physical examination and neurological examination, you cannot pinpoint the cause of low back pain in most of the patients. It is specific diagnosis, however, is possible in some patients, and you can differentiate between the origin of pain from the muscle, joint, or ligamentous structures. You can differentiate if it is a mechanical pain